This patient, he's an young person, has had an ACS with ischemic left ventricular failure, had undergone angioplasty to the circumflex as well as right coronary artery. Now has an LAD proximal tight lesion, doesn't appear to be heavily calcified, but distally the vessel appears to be calcified in the distal segment beyond the diagonal branch. So our plan is to do imaging, see the amount of calcification there, and then go ahead with that. The rest of the things, if at all an atherectomy is needed. So that's what is being planned. The lesion is quite far. Both the lesions are quite far apart. So not sure with one run of OCT we'll be able to get the entire vessel in entire lesion, both the lesions in one run. I'm not very sure. We'll do a survey mode run, 75 millimeter run, and try to acquire the image from both the vessels, both the lesions, both the proximal LAD lesion as well as the distal LAD lesion. Show the centralize the table. Okay. Come cranial. We have a gritty feeling at the second lesion. The first lesion, the wire went in without any difficulty. The second lesion appears to be the more important, significant one. Okay. OCT catheter. Yeah, we'll try going with the OCT catheter. Shaidi will have 20 cc syringes here. Joel, show the live image. Joji, എന്തെങ്കിലും ഉണ്ടോ? വിഷമം എന്തെങ്കിലും ഉണ്ടോ? ഇല്ല. തരാമല്ലോ. Okay, fisheye, auto calibrate. Okay. Show the wire tip distally. Show the wire tip distally. Okay. Okay, that's good. We will be able to get information of both the lesions. Joel, live image. Enlarge the fluoroscopic, enlarge the OCT image. Okay, ready? Yes. Get ready with the orbital catheter. Okay. Enable pullback. Activate. We'll have a microcatheter and exchange it for the Viper wire. Prior to that, we'll just review the images. First, we'll review the proximal image. That's the proximal image. If you could see the proximal image, there is calcification. There is significant calcification. You can see that there is some nodular protrusion at 6 o'clock as well as 9 o'clock position, and there is it's more of a focal calcification. If you look at the proximal portion of the vessel, no much of calcium. Now we are seeing the nodular calcification. Then at the tightest area, there is no much of calcification. It's more of a fibrotic lesion. No much of lipids also there. So now as we go distally in the distal lesion, there you can see in the distal lesion, you can see that at 12 o'clock, 1 o'clock, 11 o'clock position, there is calcium, and much distally, again the image was not image was not good because of that contrast stasis there, blood stasis there. At least angiographically there, the second half appears to be more of calcified. Here again you can appreciate that at the 11 o'clock to 2 o'clock position the calcification can be appreciated. Here again from it's more than 180-degree arc, from 5 o'clock to maybe 4 o'clock to almost till 12 o'clock you are appreciating calcium. It is again more of intimal, not very adventitial. Again here you can see the calcification at 9 o'clock position. So anyway, we do orbital and then go ahead with imaging. Proximally, definitely there appears to be some amount of calcium.
So in this case, proximal as well as distal lesion, you have to do orbital atherectomy, or only proximal lesion?
Nah, we felt that proximal certainly we'll have to do. Initially, before looking at these or this OCT images, I felt that the proximal lesion is not significantly calcified. We would be easily able to manage that. I thought that even distal lesion, angiographically, the distal lesion was appearing to be more of calcified. Moreover, as the wire went in, the gritty feel was, there was no difficulty at that initial lesion. Of course, it's a very discrete lesion, but then the distal lesion, as the wire went in, we had some gritty feel over there also. So now we are ready with the orbital. So we are going with the Viper wire is deep inside the vessel. I'll push it further, little more distally. I'll show you a blank cine again. You can see here that in the distal half the calcium is more. Of course, at the proximal lesion also it's present. We'll do a quick orbital of the proximal lesion and then go for the distal lesion. Okay, we'll bring it till the guide catheter. Okay, we'll position it here. Then we'll look at all the parameters. The flow is good. Okay, again you have reasonable amount of saline over there. Then again we'll see the speed. We'll see if the burr is working, the crown is working. We'll have to apply the brake. Okay, the brake is also okay. Then okay, that's working. Then the advancer is moving easily. So that's actually in lock position. We'll go inside. We'll open this. Both can be done. It usually it moves in very freely. You will centralize. Okay. We'll take a small cine to see whether it is. Yeah, that area is the that calcium is what that we'll do that at high speed straight away and down. Yeah, we'll put the brake. We'll straight away go at higher speeds because that's almost a 4 millimeter vessel. രുചി വേദനയൊന്നും ഇല്ലല്ലോ, വിഷമം എന്തുണ്ടെങ്കിലും പറഞ്ഞോളൂ, പെട്ടെന്ന് തീരും, 15 മിനിറ്റ്. ആ ഓക്കെ, കുഴപ്പമില്ല. അല്ല, ഈ കൈ മാത്രമായിരുന്നു നമുക്കൊരു ഇനി കാല് കുത്തേണ്ടി വരുമോ എന്നുള്ളതായിരുന്നു. We'll wait for 30 seconds. Hemodynamics are good. There is no much of change in pitch also. Shall we take a small shoot and then try to go distal? Looks good. Now we'll take it distally and then that particular area. Yeah, we'll again unlock it. Okay, there. We'll have the wire. Okay, then we'll have the break. Now we can do that area appears to be more of here. We'll come. We are actually going to low speeds 80,000 because okay, this yeah. I always do. I prefer doing with cine just because you can see the calcium properly. Anyway, we are seeing that. ചെറിയ വിഷം മാറും ജോജി ഉടൻ മാറും 1+25 അല്ലേ നമ്മൾ കൊടുത്ത് ഓക്കെ 25 ഫെന്റനിലും കൂടെ QT interval is surprisingly prolonged. അമൈഡറോൺ ഉണ്ടോ എന്ന് നോക്കാവോ ലിസ്റ്റിൽ നനച്ചുതരാം വെള്ളം തരാം അനീഷ കുറച്ചൊന്ന് നാക്ക് വിൽ ഗോ yes display I think that's enough. Further distally I think we don't have to go. Yeah, we'll stop. Now we'll do retrogrades and that's because it's not a 3 mm vessel. Anything more than 3 always we can go for higher speeds. But
so I'm questioning what is the importance in going slowly, whether any change in the orbit diameter.
Yes, very true. They have conducted some in vivo studies and they made out that when the speed is less, the luminal gain is much more compared to 1 millimeter per second versus 1 centimeter per second. They made out that there is a huge difference in luminal gain. That area. അല്പം കൂടുന്നുണ്ടോ കഴിഞ്ഞു 2 മിനിറ്റ് extra 25 fentanyl we given അല്ലേ okay that's fine. That area we'll do it retrogradely once again and stop with that. $30. Yeah, that's the area where the crown is presently sitting. But there is no significant change in the pitch at all. I think we'll take it out. You can push the wire. Yeah. Give us the run through wire once again. It's moving, right? Yeah. Now OCT run through wire and OCT catheter. Flow is not bad. Well, I think we'll just wire it by this. We'll take out the other wire, do an OCT pullback. Sami will take out this wire, wiper wire. Joel, in the first OCT pullback, what was the distal vessel size like? We're not clearly seeing that, alle? We're not clear. Not an issue. We'll take one more image. There, just see the vessel size. Yes, it's 2.7 max. So we'll anyway, distally we'll deploy a 2.75 max and not more than that. Let me come closer. Okay. Juji? Tarallo, naku danchara. Live view. Okay, Joel ready? Yes. BP is okay. Okay. Yes. Acquisition not possible. Huh? Okay, we'll do one thing. With fluoro itself, we'll do the acquisition. Okay, live view. Auto calibrate. Okay, enable pullback. Okay. Activate. Okay, we'll take this out. Now give us 2.75 balloon. We'll do the 2.75 into. Huh. Hmm. Hmm. വിളിച്ചതാര്? ആ. Get me a 7.5 glove. Okay, so here we'll see the proximal lesion if something has happened to that. We haven't seen any sanding or so over there, but then there is a dissection there proximally. Nothing else is seen in the proximal lesion. And then as we go to the distal lesion, again here we can see that that particular area from 12 o'clock to 1 o'clock position, you can see that nodule has been, probably this nodule has been shaved off. You can see that in the distal portion. Again, that sanding is seen clearly. As we go further distally, okay, nothing much. So at least in one area we have seen that it's really done some benefit. Yes, there we'll go. But I am not usually, we dilated it or?
We dilated across the diagonal. The place where the balloon is.
Here, we'll once again dilate it there, 14, 16, 18. 2.75 negative. Okay, once again, 14, 16, 18. Negative. Now goes in without much of difficulty. Now there also 18, a 3.5 balloon, 18, 3.5 balloon, negative. Joel, distal vessel size. Joel. Yeah, you have some disease in between, no? Even though the lumen is good, so when we deploy the stents, it's better that we cover both areas. 3.5. Yeah. Joji, 5 minutes. 5 minutes, Joji. Be ready with the stent also. Negative. 2.75, 38. Joel, distally 2.9. 2. So we go with a 2.75 stent. Proximally, Joel, we want to see the vessel size. We'll go up. 12, 14, 14, 16, 18. Negative. Pardon me? No, the vessel diameter. Okay, proximally it's almost 4. Almost 4. Distally? There, further distally, distal, further distal. Yes, there. 3 layers, we are seeing that clearly. 2.5. So we've taken 2.75, right? Did we open 2.75? We've dilated with 2.75, so we'll go with, and that low pressures. Yes, 30. 2.75, 30, yes. And the next one we'll go with 3.5. We might need a 38. And then after that we post dilate with 2.75 distally and 3.5 more proximally. I think that's in reasonable position. We'll do a cine also. And the yes, I think we'll go up there. What? 12, 14, 12, 12, 12, 12. Enough. Negative. Okay, 16, 16 and 18. Negative. ഇപ്പോൾ ഒരു വിഷമം തോന്നിയല്ലേ? അവിടെ സ്റ്റെൻഡ് വെച്ച് വികസിപ്പിച്ചതിൻ്റെയാ ജോജി. Small cine. Okay, and so in the next 38, 3.5, 30, 3.5, 30. Distally, it looks reasonable. It looks down there. There are no dissection. Yeah, 30. Please run the previous run once again. We are just overlapping, and proximally also it looks reasonable. Yeah, 30. Yeah. Then 2.75 and 3.5 NC balloons. After that, we'll do an OCT. If there is no, if there is proximal malapposition, we'll go with a 4 millimeter balloon. Sri Lakshmi, Keta. So we'll post there with 3.5 proximally. Do an OCT pullback. If there is malapposition, we'll go with a 4 balloon. So be ready with the 4 balloon also. That's enough. Now we'll do a cine. Yes, we'll go up. Soumya, we'll go up. 10, 12, 14, 16. Negative. ചെറിയ വേദന. അത് സ്റ്റെൻഡ് വെച്ചതിൻ്റെയാ. കഴിയാറായി ജോജി. യെസ് ജിനിഷ, യെസ് യെസ്. .75 and 3.5. Huh? 8. Negative. Oh, senior. Okay. 14. 14. Negative. 16. 16, 18. Negative. 18. Negative. Yes, 18. Indiflated problem. That's perforated allalla. Negative. Negative. 18. Negative. Again 18. Now 3.5. Negative. 3.5 balloon. 12, 14, 16, 18, negative. This 3.5 into 8, is it? Okay. Okay, 10, 10, negative. 12, negative. 14, 16, negative. 18, negative. 18, 20, negative. 20, negative. 20, negative. 22, negative. 22, 22, negative. OCT catheter. We'll do an OCT pullback and then decide whether we need to do something more in the proximal segment. Okay, that's good. Yes. എന്ത് ജോജി ജോജി കഴിഞ്ഞു ചെയ്ത് കഴിഞ്ഞു ഏകദേശം കഴിഞ്ഞു ഇനി 1 മിനിറ്റ് 2 മിനിറ്റ് ഒക്കെ ഉള്ളേ Okay, we'll leave it there. Okay. There are situations wherein we find it difficult to get the OCT catheter much distally inside the vessel. You can always go with a guide extension catheter and then do the imaging, but then yes, compared to the previous ones, yeah. Okay, Joel, you ready? Yes. Enable pullback, yes. Activate. Nitro. Show, yeah, show the proximal. Most proximally, probably we'll post dilate with a 4 millimeter and stop. That particular area alone, there is some amount of, in future, in case if you want to rewire it, the wire might goes between the stent and the vessel. 4 into what size? 4 into 8, yeah. Most proximal area alone, we'll do the 4 millimeter post dilatation at 14 atmospheres or so. Here, this is the tightest area where we had the nodular calcium. we can see that the stent is reasonably well opposed. On the side of the nodular calcium, there is some malapposition, which is acceptable for us. Then that looks okay. So the proximal nodular lesion has opened up reasonably well, 8.59, 10 millimeter luminal area. That's very much acceptable. There in the proximal area, the stent is not well opposed, so that area, that alone, we'll further oppose it with a 4 millimeter balloon dilatation. And then going distally, the mid portion, it appears to be well expanded, and the distal areas we have around 6 millimeter, 7 millimeter, and much more distally we were not able to get the imaging catheter there. So this looks reasonable for us. We'll just stop with a 4 millimeter post dilatation, and a final shoot we'll stop. No, just the most proximal area alone at 12-14. Negative. Tyagarajan, we don't have a fluorosafe in this particular thing, so we'll have to take a cine only there. 2 millimeter back. Yeah, there. 14. Yeah, 14. Yes, 14. Enough. Now we'll give some nitro and final shoot. മലി അവരോട് ജസ്റ്റ് പറഞ്ഞേക്കാവോ ജോജിയുടെ കഴിഞ്ഞു എന്നുള്ളത്. കഴിഞ്ഞു എന്നൊരു വാക്ക്. ജോജി, അപ്പം ഇന്നൊരു ദിവസം രാത്രി ICU-ല്, നാളെ റൂമിലേക്ക് ഇറക്കാം, മറ്റന്നാൾ എല്ലാം ഓക്കെയാണ്, വീട്ടിൽ പോവാം. ഞാനിവിടെ തന്നെയുണ്ട്. രാവിലെ റൗണ്ട്സ് ഒക്കെ കഴിയുമ്പോൾ ഇറക്കാം. Shall we pull back the wire at least halfway through till the proximal end of the stent, so that we can see the distal area clearly? Yes. Yeah. Looks good. Okay. Enough, no?